we'll be hitting acute healing physiology, chronic wounds and ulcers, diabetic foot ulcers, types of wound closure, and finally, wound care products. We've categorized these to map exactly to how you're going to be tested on the boards.
Okay, Section 1, Acute Healing Physiology, the orderly process of repair. We're starting way down at the microscopic level to track the normal, sequential process of how a wound actually heals itself.
The absolute crucial point here is remembering the exact sequence of cellular arrival. It's like a highly choreographed dance. During that early inflammatory phase, polymorph nuclear leukocytes, or PMNs, completely dominate the first 24 to 48 hours. They're your first responders there to phagocytize bacteria. Then, they're closely followed by macrophages, which step in to coordinate the rest of the healing process. Now, moving into the intermediate phase, which kind of overlaps around days 2 to 4, mesenchymal cells migrate in. Angiogenesis kicks off to restore the blood supply, and epithelialization happens at a neat little rate of about 1 millimeter per day. Finally, we hit scar formation and remodeling. This kicks in around day 21. This is where collagen synthesis is downregulated and actually reorganized right along the lines of physical stress.
Section 2, Chronic Wounds and Ulcers when healing stops. So what happens when this perfectly orderly progression just goes off track and gets completely stuck in the inflammatory or proliferative phases? Let's find out.
You've got to understand the strict clinical division here between local wound abnormalities and systemic conditions. Intrinsically, meaning right there at the wound bed, you might be dealing with a foreign body, necrotic tissue, local ischemia, an infection, or even excessive matrix protein degradation. But extrinsically, well, here you have your highly testable systemic factors. We're talking diabetes mellitus, systemic steroid use, smoking, collagen vascular disease, and chronic kidney or liver disease. And here's the major takeaway. Treating those local issues is honestly completely useless if you aren't simultaneously and aggressively optimizing those systemic factors.
Moving right along to Section 3, Diabetic Foot and Pressure Ulcers, Clinical Evaluation and Staging. Let's dig into the workup for these incredibly high-yield pathologies. When you're evaluating a diabetic foot wound, your immediate branch point is always based on the physical exam. First things first, check for signs of arterial insufficiency. If you see it, boom, immediately consider a vascular consult. Next, you need to evaluate the tissue itself. Is the wound clean, without any devitalized tissue, or is it infected? If it's a clean wound, your management really just hinges on the exudate. You're going to use damp gauze for minimal exudate, but you'll want to switch over to alginates, hydrocolloids, or negative pressure wound therapy if there's significant exudate. Now, what if it's infected? In that case, you have to look at the patient's clinical stability. Stable patients, they need surgical debridement until you get down to a nice clean base. However, patients presenting in septic shock, that's a different story. They require significant tissue resection or even amputation for rapid source control.
Now for pressure ulcers, you absolutely must know the National Pressure Ulcer Advisory Panel classification. It goes like this. Stage 1 is non-blanchable erythema of intact skin. Stage 2 is partial thickness skin loss involving the epidermis or dermis. Stage 3 progresses deeper to full thickness skin loss with damage to the subcutaneous tissue. And Stage 4? That's full thickness loss extending all the way down to underlying support structures. Think fascia, tendon, or even bone. Oh, and if the wound bed is totally obscured by slough or eschar, that makes it unstageable. You've got to memorize these stages. But here is the vital clinical pearl for your exams. As these wounds heal, they literally never stage backward, meaning a healing stage 4 never ever becomes a stage 2. You just document it as a healing stage 4.
Which brings us to Section 4, Types of Wound Closure, Primary, Secondary, and Tertiary Intention. Let's look at the clinician's actual arsenal for resolving these defects.
Primary intention is pretty much exactly what it sounds like. We're talking about wounds closed by direct approximation of their margins. But for this to be optimal, a few things have to line up. The wound has to be clean, the closure must be completely without undue tension, and ideally, the wound should be under 6 hours old. That time limit minimizes the risk of it developing into a chronic wound. A huge point to emphasize for primary intention is that epithelialization of surgical incisions happens incredibly fast, usually within 24 to 48 hours. Because of that, CDC guidelines strictly dictate that a sterile dressing must be left in place during this highly susceptible window to fend off bacterial contamination.
Then we have secondary intention, which is also known as spontaneous healing. This is when a wound is intentionally just left open. It closes entirely via epithelialization and contraction. And remember that contraction is a myofibroblast-mediated process. You're going to utilize secondary intention for wounds that are well past that initial 6-hour window, or for highly contaminated wounds. By highly contaminated, we mean bacterial counts exceeding 10 to the 5th organisms per gram of tissue. In these cases, you are relying completely on those smooth muscle cell-like myofibroblasts to slowly decrease the circumference of the wound over time.
Finally, tertiary intention. This is your delayed primary closure. We reserve this for wounds that are just way too heavily contaminated for immediate primary closure. The massive takeaway here is that waiting 4 to 5 days under observation does two really important things. First, it allows the normally low arterial oxygen pressure at the wound surface to rise. And second, it allows the natural inflammatory process to drastically minimize the bacterial concentration. So once that wound bed is nice and clean and well vascularized after the waiting period, physically closing it up is so much safer than it would have been on day 1.
All right, Homestretch, Section 5, Wound Care Products, Hacking the Healing Environment. Let's condense this totally massive matrix of products down into the absolute highest yield categories for your exams.
You definitely don't need to memorize every brand name on the market, but you absolutely must know how to pair the product's mechanism directly with the clinical presentation. Let's break it down. Hydrogels work by basically rehydrating necrotic tissue, which makes them perfect for shallow or deep open wounds that only have a light exudate. On the flip side, you've got alginates. These are actually highly absorbent seaweed derivatives. You must pair these with deep wounds that are producing heavy exudate because they physically form a gel as they absorb all that fluid. Then there's negative pressure wound therapy. This physically stimulates capillary ingrowth, and it's highly effective for things like diabetic ulcers, sacral ulcers, and honestly even enterocutaneous fistulae. Finally, metallic silver. This provides broad antimicrobial properties, making it an incredible choice for burns, chronic leg injuries, or diabetic injuries.
But hey, it's equally important to know what not to use. It is highly testable to recognize that the routine use of hydrogen peroxide and povidone iodine actually impedes normal healing. Why? Because they're directly cytotoxic to fibroblasts. Plus, if you instill hydrogen peroxide into a wound cavity under pressure, there's actually a documented risk of causing an air embolus. Definitely not what you want. And what about Dakin solution? Well, it's toxic to keratinocytes, so its use is strictly limited to a very short 3 to 5 day course, and that's specifically just to control actively infected or severely malodorous wounds.
All right, let's wrap this up by testing your active recall with a classic board question. When does a well-healed wound finally reach the original strength of uninjured tissue? 5 days? 2 weeks? 6 months? Well, the surprising answer is actually E, never. Because collagen is completely reorganized during that scar remodeling phase we talked about, a healed wound basically plateaus at about 80% of the bursting strength of unwounded tissue by 6 months. It never fully achieves 100% of its original strength. Keep that 80% plateau in the front of your mind for your exams, and you'll be totally set. But you know, it does leave us with a pretty fascinating clinical dilemma to chew on. If a wound is literally never 100% healed, how should that change the way we counsel our post-op patients for the rest of their lives?